Okay, looks like we have a good amount of people here, so I guess we'll start. And I want to start by saying welcome to RAAPID's educational session. Today's session is Chaos to Compliance. Fix your RADV documentation before CMS comes knocking. I'm Valyi, Strategic Marketing Consultant for RAAPID and founder of CV Strategic Marketing Solutions, and I'll be guiding today's session. But what I'm really thrilled about is that we have Wynda leading the presentation, a recognized expert in RADV audit strategy and documentation defensibility. She's also the Director of Risk Adjustment and Coding and Compliance for RAAPID. So before I hand it over to Wynda to say a few words and then get into the slides, I just want to say a few housekeeping points. The first is that we will have a Q&A session at the end. So what I'd like you to do is to put your questions in the little Q&A box below. You click it, it'll pop up, you just put your questions in there. There'll be plenty of time to do and review your questions, so please just, as you think of them, put them in there. The next is that anybody who's registered for the event will get a link to the presentation as well as a PDF of the slides in a couple days. And if you stay to the end, I have another bonus that I want to share with you, and I'll tell you that when we get there. So Wynda?
All right, thanks for that introduction, Kat. So today we're going to cover what it takes to shift from RADV documentation chaos to defensibility. We're also going to look at scalability and a strategy for that. So the stakes, just remember that the stakes are high. It's higher than ever. And with every role in your organization, they're going to play a part. So let's just jump right into it.
All right. So let's start with why this topic matters. RADV audits are evolving fast, and every role in your organization will be affected. So as Wynda walks us through this educational journey, think about where your team fits into the risk landscape, as well as how RADV impacts your day-to-day operations. So, and also what I'd love you to do, besides putting the questions in the Q&A section, and if you don't see it, just scroll your mouse up the bottom of the screen and it'll pop up. I'd love you to put some notes in if anything resonates with you and your team about what Wynda is talking about. Passing it over to you, Wynda. Oh. I don't see Wynda, so I think she might be just having a little bit of difficulty with the internet. So just hold on a moment, team. There's a lot of good information coming. I'm sure she'll be on in 1 second. Okay, let me just say that looks like Wynda is having a little bit of difficulty. We have a lot of great information. Make sure that you're holding on. We're going to get our technical difficulties. You know how it is on the internet. We're going to get them fixed on our end. Hold on, and we'll be right with you. Wanda, you on?
Okay, I'm back. I'm
All
sorry about
right.
that.
Oh my goodness. Sometimes you just have to get through it. So thank you everyone who held on. Wanda, you can begin. So next slide.
Okay. So can you hear me? All right. So so with the title to today's session, it's going to reflect a challenge that I know many of you are already grappling with. You have CMS who is changing the rules of the game, and they're leveraging AI extrapolation and stricter documentation standards to make sure that they recoup those overpayments. So whether you're a compliance officer, a coder, a documentation manager, or even an executive overseeing enterprise risk, we're all connected by the growing pressure to get our documentation right the first time. So this session is actually going to walk you through a practical, role-specific framework that you can actually use to transform those disjointed documentation practices into the streamline, the audit-ready operation that you already have. We'll also look at how the leadership can actually strategically support this transformation so that it's not just about fixing the errors, but it's also going to be about protecting the organization's bottom line and the reputation. And I know that's important to everyone. So with that being said, we're going to go ahead and jump right in. So, Kat, I think you've
Yeah,
already
go ahead,
probably,
Wanda. I
okay,
already gave the intro to this slide.
okay, all right. So CMS isn't just checking the boxes anymore, and I'm sure that's what Kat had already told you. RADV audits now reflect the enterprise risk. So we're looking at from the reimbursement losses to the reputational damage. And each role, whether you're a VP, a director, compliance, officer, if you're a coder, everybody is facing those unique exposure. And we're going to walk through this with some clear solutions. So let's talk about why this webinar isn't just important, but it's also essential. So CMS has ramped up a RADV audit program with AI-enabled tools. They have targeted larger sample sizes that they're targeting and the aggressive extrapolation methods. That means that even a few unsupported diagnosis codes can actually result in major clawbacks that's across your entire population. For executives and VPs, this is actually a financial risk as much as a compliance one. Next slide, please. Many organizations for you VPs, I know you are now budgeting for that overpayment return even before the audit hit. Reason why is because you're essentially planning for failure. For compliance and audit teams, the pressure has never been higher. Those unsupported diagnoses are no longer occasional errors. Instead, they're being looked at as systematic weaknesses. Managers and directors, you're on the hook for aligning documentation workflows across the departments and for making sure that you're proving that they've done enough to prevent those errors proactively. And coders, I haven't forgotten about you either. CMS has raised the bar on what counts as verifiable. So this is very important for you that if a diagnosis isn't clearly backed by meet criteria, if it's not supported, remember, it's no longer defensible. So no matter how common it was in the past, you're now going to have to make sure that that meet criteria is there, that every diagnosis that you choose, it is supported. Keeping in mind, every role in this ecosystem is now directly accountable for audit readiness. The question is not why. The why isn't just compliance anymore, but the why is about the risk, the dollars, and also making sure that we're protecting your organization's integrity. Next slide.
Well, that was a clear vision of why and how everybody in the organization is going to be affected. So now that we've seen, this is where we understand about the documentation, and that we know that we've all seen that documentation is technically present, which means seems to be what we're used to seeing. But the bigger question, Wanda, and the challenge is, can you defend the documentation, right? So in these slides, Wanda's going to break down where those gaps tend to hide and who they will impact the most. And it'd be great if you, as you're watching, and if you see patterns that you may have seen in your own charts, let us know.
Yeah, that's right, Kat. So just keeping in mind that these aren't just hypothetically or hypothetical. You have ambiguous language that's in your charts. You have missing meat, which results to unsupported HCCs, and they just seem to be showing up everywhere. With that being said, CMS is auditing with precision. They're identifying these patterns. So by doing this, we need to make sure we identify these patterns. And let's move from being reactive and having those reactive fixes to making sure that we have proactive control. Next slide. So now let's shine a spotlight on the common cracks in the documentation wall, the same ones that CMS AI is trained to detect in just seconds. First, we're going to look at the ambiguous clinical notes. We've all seen them. This isn't anything new. You have phrases like history of diabetes or hypertension stable without any type of context. These offer no clear support for coding, and they become major flags in a RADV audit. So we need to make sure we fix these. Second, we have that missing meat evidence. So if a diagnosis isn't being actively monitored, evaluated, assessed, or treated, and I like to always use the term of supported, it just won't hold up. Remember that. The meat evidence, the monitor, evaluate, assess, or treat it is just to help you out to say, as I look at this diagnosis, I need to make sure that it's active. Is it really active? Has the provider monitored the condition? Are they evaluating the condition? Have they assessed the condition? Or is there treatment for the condition? Remember, that's what that's helping you for. But the bottom line here is support. So coders may flag this, but the root often lies in the provider habits. Then third, we have EHR versus the submission mismatches. So what gets entered into the EMR doesn't always make it to the encounter data submission file. This is where we have a disconnect, and this disconnect is often invisible until CMS comes around. And then when CMS comes around, they compare the source data, and then they end up finding those discrepancies. Then next, you have the suspect HCCs. You have overcoding or assigning diagnoses that sound impressive, but they actually lack that clear clinical backup. This can result in those clawbacks, even if the intent was accuracy. And then finally, we have inconsistent documentation practices. So if you have one provider that documents thoroughly and another that does not, or they only do the bare minimum, you actually end up with unpredictable audit exposure. And this can be by specialty or it can be by provider. So keep in mind that by pinpointing these patterns early, we can actually shift from damage control to data defensibility. And that's exactly where our Fix It framework is going to lead us next. Next slide.
So I guess now we're going to talk about the anatomy or really understand an actual RADV audit. So this way you can get a sense of how you would walk through the audit process. And while she's doing that, I'd love you to consider your current workflow, and is it built to withstand the level of document scrutiny that Wanda just outlined? And I know you have a lot of questions percolating. You should, and so remember to jot them down in the Q&A section. There's plenty of time at the end. We're definitely gonna have time to respond. Wanda?
All right, so CMS starts small. At least we know for the Con 19, those of you who may be involved in that currently right now, you can see that this one is small compared to where they expect to go. But those findings actually get extrapolated across your entire population. So errors, again, aren't isolated. They become system-wide liabilities, and understanding each audit phrase will help you prepare every team member for that defense that we need. Next slide. So now what we're going to do is we're going to walk through the anatomy of a RADV audit. Again, remember, this is not completely inclusive. We're going to give you as much information as possible. You know, we don't have a whole lot of time, so I'm just going to be touching on each part of this. So step one is the sampling methodology. So CMS doesn't review every chart. They only sample. But what they're doing is they're using a stratified random sampling, which ensures that the different risk segments are represented. This is going to become the foundation for the extrapolation later. So even a few bad apples in your sample can actually taint the whole bunch. Then second, we have the documentation collection. Here, you'll be asked to submit your complete medical records for certain dates of services. This is where your gaps are often first discovered, not because you did anything wrong, but because the providers were real vague in their documentation, or you have some of those key meat elements that were missing. Again, as I was saying earlier, there's no support. Then third, you have the medical record review. Now it's time for CMS to take their clinical coders and they're going to look at every one of these chart notes that have been submitted so that they can confirm the diagnoses. They want to make sure that those diagnoses are not just listed in the chart note, but that they're being actively managed. So we talked about that earlier on making sure that that support is there, making sure that it's an active condition on the date of service and not that it's a condition that they put and maybe the patient had it last year, but they really don't have it today or it's been cured. If something's missing, even if it was clinically accurate, remember it's unsupported. Then we have step 4. This is your error rate determination. So if you had 5 out of 30 sample charts that showed unsupported 𝘀cie, you could possibly be looking at about a 16.7% error rate. And then that takes you to step 5, which is the extrapolation. This is where it gets serious. CMS applies that error rate across the entire at-risk population. So now that 5 chart issue might lead to a 6 or 7 figure repayment that's going to have to be given from your organization. So again, this is not just a coder's problem. It's a systematic risk. And I know you're going to get tired of hearing me say this, but I'll be saying it throughout the entire presentation here. It's a systematic risk that affects your organization's review cycle, the compliance posture, and the executive oversight. So this now brings us to how do we fix it? What is it that we need to do next? Next slide.
Yeah, as Wanda mentioned, now we're going to talk about solutions. Wanda's going to dive into some nuts and bolts and specifically the fix-it framework that she mentioned earlier, which is a 4-step framework that's designed to be scalable and role specific because as we know, this touches a lot of different roles. So as Wanda walks through the framework, I'd love you to take a moment to consider which of the steps your team could or should activate first. Just put that in the Q&A and we'd love to hear your notes. Wanda?
All right, so documentation challenges we know can feel very overwhelming. Trust me, been there, done that. This framework is going to break the remediation into structure, repeatable phrases, from data reconciliation to audit simulation. You don't have to fix everything at once. That's what makes this scary. But remember, everyone can fix something right now. So let's go into the heart of this presentation, and we're going to actually talk about how do we actually move from documentation disorder to compliance resilience. Again, this is so great and this is so important. I wish we had more time where we could dive into this in a lot more detail. But again, we're going to hit enough of it so that you have an idea. And if you have questions, definitely feel free to stick them in the QA chat, as Kat has been mentioning. So how do we actually move from documentation disorder to compliance resilience? I'm going to give you a 4-step framework that can serve as your operating system for RADV audit readiness. It's tactical, repeatable, and role aligned. Even as we go through this and we talk about the different roles, just remember that in your organization, the roles may be different, but I'm sure you'll know how to fix this and where to put it and who to give it to. So, step 1 is your retrospective data reconciliation. Now, this is where you can match your encounter documentation against what was submitted to CMS. You'll be surprised how often that you can find a valid diagnosis that's actually missing from the submission, or even invalid ones that are left in that was submitted. So this step is going to help you detect those systematic flaws in an upstream data pathway. Step 2, you want to target the chart reviews. There's no way, and we don't need to, you can't and you don't need to try to boil the ocean. So what you need to do is you need to focus on the audits that are for your high-risk cohorts. Those conditions like diabetes with complications, your ischemic heart disease, or even the outlier providers that have historically have high 𝘀𝘀𝘂𝗍𝗂𝘁𝗍. captures. These are the ones that you want to concentrate on for your target reviews. If you concentrate on those for target reviews, it's going to give you a defensible way to be able to prioritize. Then you have step 3, which is your provider education. So coding
Hey, Wanda.
accuracy is only as strong as the document.
Wanda, you broke up there, and I don't want anyone to miss anything. If you could just backtrack just a little bit.
Okay, so again, I'm going to back up here just to talking about the targeted chart reviews and stating that you don't need to boil the ocean, but what we want to do is we want to focus on your audits on those high-risk cohorts. Those high-risk cohorts can be your conditions like diabetes with complications, your ischemic heart disease, or even the outlier providers with historical high 𝘀𝘀𝘂𝗍𝗂𝘁𝗍𝗂 capture. Again, this is going to give you a defensible way to be able to prioritize. Then we have the provider education. So coding accuracy is only as strong as the documentation behind it. If the meet criteria, if the support, if it's not there, if you don't have the clinical language or the language that is there is just too vague, if coders you have your coders that they're just being left stranded. So they're trying their best to find the support within the documentation, but without the meat, without the strong clinical language, they're just not going to be able to pick those conditions up. So what you need to do is you need to make sure that you equip your providers with feedback loops. You need to give them mini toolkits, and then also those documentation do's and don'ts. This will help the providers to make sure that they're documenting appropriately and that their documentation is clear, concise, and accurate. Then step 4 is the audit simulation. This is where the technology is going to earn its keep. You have your NLP-driven platforms that can pre-review charts against CMS audit logic. They will flag unsupported diagnosis, and they also will simulate your risk exposure. You have the NLP that's out there, and then something that's a little even higher than NLP that a lot of you may not have heard of is also your neurosymbolic AI. So that's even better, that it's going to catch the things that the NLP itself is not catching. So keep in mind that it's all about failing safe. So before CMS reviews your data for real, you need to make sure you're doing what you're doing. Each one of these steps can actually be operational by stakeholder groups. You have your coders, your compliance, your clinicians, your analysts, and also your executive sponsors. So this framework works not only to just plug in the gaps, but also to make sure that you're institutionalizing those audit defensibility. Next slide.
I love how you laid everything out and connected it with the different positions within the organization. So it's a small slide, and maybe just one slide, but it was packed with information. So the next thing we're going to talk about is that there's an extra step, and that step is it's something that folks need to consider nowadays, because it's not a nice to have, it's a necessity, and that's technology. So what I was hoping is that as Wynda goes over this information, if you could share if you're currently using an AI or audit simulation platform, we'd love to hear it. Wynda?
All right. So again, a lot of people, a lot of companies, they haven't actually invested in technology yet, or the technology that they've invested in is very limited. And that's just simply because I know technology is very expensive, but it's no longer an option. As CMS is using AI, you need to make sure that you're matching that capability with an NLP or a neurosymbolic platform, a predictive analytic platform, and then also the documentation guidance from at a POS, your point of service. Audit simulation tools in particular will let us test that defensibility before CMS does. Next slide. So now what we're going to do is we're going to actually take a moment to talk about how technology, specifically AI, can actually help close those loops, close the documentation gaps before CMS gets a chance to even open it. CMS is using AI, as they have stated to us, to make sure that they spot those unsupported diagnoses, scan for the statistical outliers, and also challenge the payment integrity. If you're not using a similar tool on your side, you're essentially playing a defense without a helmet. So in order to be in this game, you've got to play the game fairly. And that means to play the game fairly, you need to have AI tools just like CMS is using. So we have our NLPs, and you heard me talk about it earlier. A step up from the NLPs is also your neurosymbolic AI. So with that, for instance, you can rapidly analyze those medical chart notes, identify those ambiguous phrasing that may fail an audit. It also highlights documentation that doesn't support the meet criteria. So before your coders ever even touched the chart, this system is working, and it's going to do what it needs to do, which is going to make it a lot easier for the coders. Then you have your predictive analytics. It's going to help your team prioritize the audit risk by flagging those encounters that are most likely to be problematic. And it's most likely to be problematic based on the coding patterns, the provider trends, or even prior audits. So that kind of proactive focus means less wasted time and fewer surprises. Then you have your audit simulation platforms. These are game changers. They mimic a RADV audit logic so that you can test your defensibility in a safe environment, at least well before, CMS actually reviews your data. Then you have real-time documentation guidance, which supports your frontline providers. Imagine a tool that can actually prompt the provider to say, add the treatment plan here for COPD, not after the denial, but right during the encounter. Wouldn't that be golden? I think it is. And then finally, you have your dashboard and risk reporting, which will allow those executives to see what's working, what's vulnerable, and where they need to invest. Because this isn't just documentation. Again, it's a strategy. The bottom line here is that AI isn't replacing your team. It's amplifying their accuracy, speeding up their reviews, and it's making the audit defense not just possible, but predictable. Next slide.
Okay, here is where we put all the great information together and it comes to life with a case study, a real world example. So this case study is going to show how, and if you could believe this, a single unsupported diagnosis can trigger a six-figure clawback. So Wanda's going to go through that, and she's also going to touch on how proactive mindset and process can prevent this. Wanda?
Absolutely. Thank you, Kat. So, a few unsupported codes, just one vague note can be $250,000 in extrapolated risk. That's the reality. I'm not just making this up, but this is the reality of RADV today. So, with the right education, templates, and simulation tools, we flagged and fixed this before the next audit round comes about. That's the kind of turnaround we're actually after. So, that's what we're going to talk about here now. What can we do? That right education, template, the simulation tools so that we can flag and fix the problems. Next slide. So now what I'm going to do is I'm going to show you how just one single phrase or the lack of a phrase can actually cost your organization possibly $250,000. So this is a case that actually came from an audit where a 72-year-old male chart was selected. The diagnoses submitted actually included diabetes with complication, CKD, and CHF. However, the documentation just simply said DM2 stable and CKD noted. Continue current meds. There was no mention of meat. You didn't have your monitoring, your evaluation, your assessment, your treatment, and then CHF itself, it's not even referenced in the visit. So CMS rejected both HCCs. That might seem small, but in a 30 chart sample, these two rejections actually push the error rate to 16%. When extrapolated across the population segment, that turned into a $250,000 clawback. So what fixed it? What was needed? There's three things: educating the provider on documenting the treatment plans and the clinical indicators, updating the EHR templates so that you can make sure it prompts the providers for those meat elements, and then running the chart through an audit simulation platform, which would have actually caught these gaps before CMS ever even reviewed the case. So the takeaway here is defensibility. It's not about the intent. It's about what explicitly is being documented. And the difference between the red and green can actually be a handful of clinical words. Next slide.
Excuse me. I know we have a mix of titles and roles watching today, but I feel that this section you'll find is especially relevant for executives. And the question is why? Well, and now I'm going to sound like you, Wanda, because RADV risk isn't just operational, it's strategic. So as you listen, consider how your governance structure supports or hinders your current audit readiness. Wanda?
Yeah, that's correct, Kat. RADV, again, is not just a coding problem. I keep saying this over and over again. It's not a coding problem, it's a strategic one. So when audit risk makes it onto the governance agendas in the EMR dashboard, it's going to gain some executive visibility and funding, ownership, and also performance accountability will follow. Next slide. At this stage in the presentation, we've covered the technical and tactical aspects of RADV documentation. But now what we're going to do is let's zoom in and let's focus on what really drives that sustainability change. That is your executive strategy alignment. We've got to make sure we align the executives. RADV audits are no longer just a compliance issue. They're a revenue cycle, vulnerability, and also a reputational risk. And if they're mismanaged, it's going to be a governance failure. So what do leadership teams need to do to make sure that this does not happen? You need to first elevate your audit exposure to enterprise risk. If overpayment clawbacks aren't already on your board's radar, it's time that they are. Integrate RADV risk into governance discussion. If you do this, it ensures that it gets the oversight and the resources that it demands. Second, make sure that you quantify the ROI of getting documentation right. Show leadership that proactive remediation is an investment. It's not just an expense. A $50,000 technology upgrade can prevent a $2 million extrapolated recoupment. And that's executive math. Third, align your departments. You have compliance, IT, your clinical team, legal, and all the other teams that you may have. They all need to operate from a shared audit playbook. Executive sponsorship is what gets those silos talking. And fourth, assign owners. When nobody is responsible for the audit strategy, documentation risk becomes everyone's problem and nobody's priority. So assign a VP or a director to make sure that they champion this. Create a scorecard, make it real. And finally, drive a culture shift. Compliance isn't punitive, it's protective. When provider education and documentation KPIs are baked into performance reviews and incentives, quality becomes self-reinforcing. So strategic alignment isn't just about protecting today's revenue, it's about ensuring that your organization is defensible, efficient, and credible for many more years to come. Next slide.
Those are all excellent points, and if everyone is, if it's everyone's problem, then everyone needs to know the solution. And this is where you're going to dive in to discuss action plans and next steps, because, like you said before, ultimately we need to understand how we move from a reactive state to more of a resilient one. So here you're going to break down what each role can do starting today, which is an excellent slide.
Perfect. So whether you're a coder, a director, or an executive, remember you all have a role to play in compliance. This matrix is just going to outline what you can do next and what you should build toward. That momentum is going to start when everyone moves together. Next slide. So everything that we've discussed here today is only as good as what happens after this webinar ends. So let's get practical. What you have here on this slide is it's going to give you that roadmap. It's tailored by roles. And as you heard me say earlier, all of these roles may not necessarily fit your organization, but I'm sure you'll figure out who that role is and where you need to put them in order to make this work. And this is for how to transform these strategies into tangible outcomes. You have your executives. The time for awareness is over. You'll want to make RADV audit risk a formal part of the governance conversation. That means asking for those dashboards that show the extrapolation exposure in the documentation defensibility. Today, don't wait till post audit, but do it today. Over the next 90 days, consider budgeting for audit simulation tools and integrating your documentation KPIs into an incentive plan. For managers and directors, you own the translations of strategy into consistent processes. So run those quick audits by specialty or by service line, and then build your standard operating procedures for your provider feedback, your coding QA, and also the remediation response cycles. Your compliance teams, start with retrospective reviews now. Even a small batch of samples can reveal patterns. Then work with your tech leads to make sure that they simulate an audit logic that's using internal and vendor tools. This will help you go from reactive cleanup to predictive control. And coders, remember, again, you're the front line. You need to use what we've discussed here today and identify those unsupported diagnoses. Standardize your annotation process so that there's documentation for why something was accepted or rejected. And make sure that your providers are in the loop. They're not just documentation sources, they're also compliance partners. And the most compliant organizations aren't the ones that have no errors at all. They're actually the ones that are documented, repeatable processes, and they're able to catch and correct those errors before CMS does. Next slide.
All right. Excuse me. All right, we've reached the Q&A time. And we do have a couple questions. We did go a little over because there was the just a glitch in the beginning. But let's go through a couple of questions. Wanda, I think this will give a lot of insight as well. So here's the first one. Let me put my screen on. So here's the first one. It's how can we prioritize chart reviews when we can't audit everything? So I guess there's only a percentage of the charts that are going to be pulled. So how can they prioritize their charts to audit?
So I think when it comes to that, we're going to have to start with a high impact target. The conditions with the chronic complications such as diabetes and CHF, look at your outliers, providers, and then also those charts that are tied to the large risk scores. They're going to need to use those predictive analytics or audit simulation tools to make sure that you identify the riskiest encounters first.
Okay.
Kat, I think also in your Q&A, there's some questions there. I don't know if we're going to be able to get to all of those here today. We may have to.
Yeah, there's a few technical questions here. And let's see. Well, let me read this one. Is the CMS RADV audit logic available to train the audit simulation tool in step 4? I'm not sure if, I mean, I'll put that one out there, but that might have to be a technical answer that we may have to put to our text, but maybe you can answer it as well.
Yeah, so with that, I mean, when it comes down to the CMS audit logic, I think, again, it's going to depend on what simulation tool that you have, but yes, some of those should be able to take in this CMS audit logic and be able to put it into, import that into the simulation tool so that that simulation tool is working the same way that CMS would actually be doing, so that it can give you more of an accurate result on what would happen if this was a real RADV audit.
Okay, so I think we could squeeze in one more quick question, and then we'll quickly wrap up. Let's see. What should we do if our documentation doesn't match submission files?
So if your documentation actually does not match the submission file, you want to make sure you immediately reconcile the source data and the submission files. These mismatches, as I mentioned earlier, can actually result in automatic rejections, even if your chart was compliant. So consider involving your IT and your coding team in a regular reconciliation cadence. That way you can make sure you go through all of this information and make sure that it is reconciled.
Okay. Well, I think we just got another question in, but I do you think we can answer one more? Everyone seems to be hanging on, so. But, okay, I'm going for it. In the RADV scenario you used, Wanda, did CMS allow 𝘀cie𝗹𝘂𝗁𝗂 even though the only documentation was DM2 stable?
That's a good question. Let me go back up and look at it. I can't remember if in this instance, if they actually allowed the 𝘀cie𝗹𝘂𝗁, because again, I understand exactly where you're coming from. This is one that we've always looked at, is that stable is meet by itself. So since stable is looked at as meet, the question is did CMS allow this DM2 as being stable, or was that one that was taken away? Let me go back and actually pull this one and look at it, and we'll get you an answer to that when we send out the answers to the rest of these questions.
Right, that's right. Any questions that we don't get to here, we're definitely going to make sure that's part of the package of stuff that you get post session. So with that, I think we've come to an end. This was a great presentation. This was a great session, and I want to thank you all for participating and waiting with us and hanging out while we had a little glitch, but it was worth every minute because Wanda provided such a great information. And thank you, Wanda, for that bounty of information. So as a reminder, everyone will receive a link of the presentation, and within a day or two, they'll receive a PDF of the presentation. The special item I talked about earlier had to do with that we did a survey of the industry on RADV audits and the risk, and we got some great information, and a report is being pulled together, and we're going to provide that to you as well. So look for that in a couple days. And finally, I want to say, let's please stay connected. Stay connected with RAAPID, who's a leader in innovative and AI in risk adjustment and compliance. Follow us on LinkedIn. Make sure you follow me and follow Wynda Clayton and other RAAPID team members, because as we continue to develop high quality educational tools and solutions, industry leading solutions, we want to hear from you. So thank you again from everyone at RAAPID, and thank you for joining us today for this educational session.
Thank you so much.